Thanks for joining us today. Nice to have a group of people along to listen in. This is the third of the supporter webinars that we've done for Western Health Foundation, and really glad today to be having a fantastic group of speakers who are going to share some of their experiences with you, and it's been some great response that we've had to the earlier ones as well, so glad to be sharing it. We'll kick off now, and as other people jump on, they can join in, but just to keep the ball rolling. So welcome, and again, thanks for joining us. Most of the people joining us today are supporters or corporate sponsors of Western Health through Western Health Foundation, and thank you for your support and for your commitment to the foundation. I know it's been a tough year for some, so especially those who are continuing on as supporters, we really appreciate it. I'm Julia White, I'm the Director of Western Health Foundation, and I'll introduce you to the rest of the panel in just a moment. I'll start by acknowledging the traditional owners of the lands on which Western Health is based, the Bunwarong and the Waiwarong of the Kulin Nation, and pay my respects to their elders past, present and emerging. As I said, really happy to have a great group of speakers here to join us, and I'm sure you'll get a lot of interest and insight in the discussion today. We do also have a poll that we'll be running, just a very quick anonymous poll assessing the COVID impact on businesses, and we'll share the results of those with you as we go along in the session today. This little talk will run for about an hour, just under an hour, and there will be time for questions towards the end. The Q&A button at the bottom of the screen, feel free to post your questions. If you want to put it up early before we ask for questions, more than welcome to, and if we can during the conversation, we'll get to it. Otherwise, we'll get to it as we come towards the end of the session. And so now let me please introduce you to the fantastic panel that we have here today. We're joined by our CEO, Russell Harrison, our Head of Infectious Diseases, Marion Kainer, who has only joined us probably about 6 months before the COVID pandemic really sort of took off globally, and we are incredibly fortunate that she was with us by that stage, and you'll hear a little bit more about that shortly. Jason Plant, Divisional Director of Perioperative and Critical Care Services, is also with us, as is Associate Professor Craig French, who's the Director of the ICU unit at Sunshine Hospital. So thanks to you all for joining us. We've also got Sue Ellen Bruce, who's acting as our moderator today, and Sue will lead off now with some questions for the team, and I'll check out and I'll come back later, but thank you again for joining us. Thanks, Sue.
Thank you. Thanks, Julia, and a welcome to our corporate friends again. I probably would like to start with just, some background that we all really know, but I think it's important for context with how we have managed through our COVID pandemic. And many of you have your businesses in the West, so you know that Western Health, well, you would understand that Western Health was in quite a unique position as we were surrounded by many of the hotspot postcodes that occurred during the first and second waves. And that also included our staff. Many of our staff live in our community where they work. And so that gave us a few challenges that maybe other health services didn't necessarily deal as much as we did with. Also during this, by the end of the second wave, of what we refer to the second wave, Western Health had actually cared for over 400 COVID positive patients and over 70 COVID positive patients in our ICU. And we also supported over 28 aged care facilities during the outbreak as well in the second wave. But today our panel is going to talk about some of their insights and learnings with you, but with the ICU lens on. And I've said this before, but we've heard the phrase, it's like building a plane when flying it at the same time. And although it probably more like we were flying a Tiger Moth and maybe had to turn it into a jumbo plane might be an accurate reflection of what we did. Nothing could have been truer than the work that was done to get our ICUs organised and ready to go. And they certainly were pressure tested during the second wave. And so we'll hear a bit more about that. But before I ask Craig, who'll do a bit of a presentation for us, I wanted to start with asking Marion, a couple of questions. And Marion, you were in a similar position during the SARS outbreak, and we want to know a little bit about how that helped you prepare us for the potential that we were to experience, and share a little bit with our corporate group about your experience otherwise from SARS that helped you help us.
So, as was mentioned earlier, I joined Western Health in October after having spent 19 and a half years in the United States, where initially I was at the Centers for Disease Control and Prevention as a disease detective. And then I was in Tennessee at Vanderbilt University, as well as the Tennessee Department of Health. And there in 2003, I was really involved with our response to the first coronavirus that was a real problem for mankind, and that was the SARS coronavirus, where we had suspect cases and we needed to make sure that our hospitals were all ready to protect staff and other patients from transmission of that, and ensure that the hospitals were ready for a potential significant increase in patients, which could overwhelm the health service, that is including the intensive care units as well as the general wards. And so infection control and protection of staff and patients is absolutely critical in that, in ensuring that the staffing is available to care for patients and have the best possible outcomes. So I was involved. So Tennessee has a state of 6.5 million people, very similar to the population of Victoria. And so I was intimately involved with working for with other health services. And I saw the devastating impact that if you did not control SARS coronavirus, what that could do. And so that was incredibly helpful in planning for SARS coronavirus 2 from January of this year onward. In addition, I was also involved with the second coronavirus, which had been impacted in the world, the MERS coronavirus, for Middle East respiratory syndrome coronavirus. And I also had a background with regards to influenza pandemic planning. I had a stint working with the Department of Health in Victoria back in 1999, involved in influenza pandemic planning, and worked with colleagues at the Centers for Disease Control and Prevention for modeling. And there I really saw the tremendous impact that flattening the curve would do to protect our healthcare services. And we did an inventory at that time of intensive care unit beds in Australia and New Zealand, as well as ventilator capacity. It became really obvious that we also really needed to work with our community to really flatten the curve to prevent the overload of healthcare service, to ensure the best possible care delivery.
Thanks, Marion. And so Russell, did knowing that we had Marion on board and she was starting to talk about how we would plan, make you feel calm and confident, or nervous and anxious? And then how did we respond?
I'm always calm and confident, and I only knew half of what Marion just said about us, so I feel really pleased we got her. I guess in all seriousness, a bit like Marion, I came from overseas, and our view of planning for SARS and things was a bit different to what I was experiencing in January in Victoria. So Marion and myself and some of the leadership team had a chat, and we pulled people offline of various expertise in early February, might have been a third or fourth, to actually create a Western Health planning cell. So we had Marion from an infectious diseases perspective, we had infection prevention and control people, operational managers, and some senior nursing leadership. So we were able to start to look at, well, if this is going to happen like it is in the rest of the world, what do we do at Western Health? How do we protect our community, our staff, and keep functioning? We're not allowed to close the doors and say, thank you very much, go somewhere else. We're a service that has to be here. So we had to start to move pretty rapidly and pretty quickly. And I liked your analogy of the tiger moth becoming a jumbo jet, because to quote Marion, we were very dynamic and fast moving. And particularly in those early days, the guidance was changing probably every hour. And people on the call might recall all the border announcements that were getting closed and where the hot zones were and who couldn't travel or fly in. And so we had to kind of keep the staff up to date, but keep planning. And I think the fact that we've had that planning cell doing probably about a good month's worth of planning before the rules really sort of start to come in for some of the sort of more serious stuff, we were very well positioned. So, I think Western Health has performed excellently across, but that's because of the hard work that Marion and the people in the team did up in advance, and the rest of the organisation then jumped on board with.
Thanks, Russell. So by this time, we're also starting to get pictures from overseas in the beginning of the first wave, pictures from Italy and Spain, England, of unwell people and overwhelmed hospitals and the burden on intensive cares. So before I hand over to Craig to start his presentation, Jason, I was going to ask you, what were kind of the things you were thinking that were heading our way, and what was some of the planning that was going on in your head?
There's just before that, Sue, I was reflecting the other day about our AGM back in November, and I don't know if you remember this, Marion, but we actually sat next to each other. So you had just been announced, and I didn't know what you looked like, so I didn't know it was you. But reflecting on that, I think it was one of the best things that could have happened to us in our preparation for the pandemic that was to come. So that was probably the first reflection I had there, and then. You're right, Sue. We were watching the news very closely, reading all the articles that were coming out of the US and the UK and Europe in general, and specifically, I think it was Lombardy in Italy. And we started to go, wow, this is the big tsunami that's heading our way, and how do we prepare for that? So a lot of engagement with Marion and her team about what we needed to do in terms of prepare and keep our staff safe. So all the guidance around PPE and managing these patients. So we protecting them, but also protecting our staff. And then the conversation came around pretty quickly around what do we need to prepare for in terms of our capacity. So the numbers that we were getting from various sources, largely from the government Department of Health, was astronomical. And how do we need to turn our hospital into, with ICU in particular, how many ICU beds did we need? How many ventilators did we need? So we're quickly looking at beds, alternative places, because we've got the 2 ICU units with 27 beds, 18 funded beds, but we're looking at in the initial phase, looking at 120 that we needed to look after to contribute as a Western Health perspective across the whole state. So that was the first thing. That wow, there's this big tsunami coming, and how do we prepare for the volume of patients that we're predicting that we needed to look after on a ventilator?
Great, thanks, Jason. And Craig, you might want to lead us into your presentation, but, in particular, I guess you're going to cover for us, where we started from and how we managed and some of the great outcomes. So I might hand over to you to share your presentation.
Yep, I will do that. Here we go. All right, thank you. And I obviously just reiterate what Russell and Jason and Marion have said about the extraordinary amount of preparation that went in at Western Health to manage the demands that were placed upon us, and even we were preparing to manage much bigger demand than actually turned out to be, in an environment that was constantly, as Russell said, constantly changing. The advice was changing sort of hourly. And that uncertainty actually then, often from a leadership perspective, that uncertainty was exceedingly difficult to manage within the broader population of our staff, but also the community as well, because we didn't really know what was going to happen. There we go. So really that was regarding the fear, and that fear was actually present amongst all of us, whether we worked in healthcare or not, the fear of not knowing what was going on. Those of us in healthcare felt a bit like we were standing on the abyss and the tsunami was coming. And I was certainly regularly in contact with some of my colleagues in Milan, and hearing the stories of what was happening there in January, or sorry, February in particular, into March, and the demands that were being placed upon them, and how they were what they were doing to try and manage the patients that they had, and how they were changing practice to adapt to an increasing demand. But that change in practice may not have been necessarily evidence-driven. It was driven a lot by what they thought was best, and also driven in some aspects by fear as well, fear of whether as healthcare workers we were going to get this infection and we could be seriously unwell too. And we've all seen pictures in the various media of satellite ICUs, unfortunately people dying from this illness, and graves in outside of normal cemeteries being constructed, and obviously mortuaries in parks, and all sorts of horrible images that we were experienced to and added to the fear. And so really there were lots of reports coming from overseas, and they were telling us to do, sorry about the medical sort of terms on this, but they were telling us to do all sorts of things that that we didn't do in previous influenza pandemics, like intubate early and prone them early, and triage by age. Certainly in Lombardy, if at one point in time that was happening, keep them dry, and all sorts of things, which from a medical perspective were being rapidly introduced into practice, but we really didn't know whether they were influencing outcome, or whether these things were being done because the number of patients that was presenting was demanding the staff to treat people in a uniform manner that could be done by someone that didn't necessarily have a great deal of critical care experience. So these are some of our, if you're talking about our toolbox, these are some of the things that we can do in ICU. So we deliver oxygen, and there's a number of ways that we can deliver oxygen: by standard masks. We can deliver them by special masks and prongs. The NP is for nasal prongs and HF is high flow. We can deliver ventilation invasively, that's mechanical ventilation, or non-invasively. We can do lots of medical procedures, as you can see there on the right as well. But many of these also are considered high aerosol, what's called aerosol generating procedures. You may have heard of some of that in the press as well. But many of these therapies are believed to actually increase the risk of healthcare workers of getting SARS-CoV-2 infection, or COVID-19, related to the formation of the virus being transmitted in little droplets and then spreading through the air. There was little data regarding this in the literature from previous viral pandemics, and therefore, because there's little data, there's lots of uncertainty, and that led to fear. And so this basically meant that many of the things that we would normally do in intensive care were either said, you're not going to do these anymore, or you're going to do them. If you do them, they're extremely high, risky sort of things to do. So it actually we were limited in a way in some aspects to how we could treat our patients. So similar to, I guess, in parallel with the process of how we could expand our service, that should that be required to do, and the amount of work that went on with that, we also sort of really face this dilemma of how best to treat our patients with this infection when we can't do what we normally would do, and also how best to protect our staff when the therapies that we would normally provide may increase the risk to them. So just for the photo on the left is from the Footscray ICU, and it's an open design. That means that you can just see it's curtains between the bays. In most modern ICUs that have been constructed in the last couple of decades, they're closed. That is, each patient is in their own individual room. And obviously, being in an individual room rather than in a big open area, the potential for transmission of infectious agents from one patient to another is reduced. In addition, there's isolation rooms. They protect those people outside the rooms. At Western Health, we only have one isolation room in each ICU. And we had this with the swine flu pandemic in 2009, when Western Health treated a large number of swine flu patients. And we were also at that time asked to treat them outside isolation facilities. So we had to come up with some innovative ways. Now, you've probably heard a lot about ventilation. We can't open the windows in the hospital. We can't increase the ventilation, but there is increasing evidence that adequate ventilation or higher levels of ventilation reduce the risk of healthcare worker-associated infection, or indeed infection in enclosed places, in workplaces and other areas as well. So we thought we needed, our first sort of idea was what we're going to do. How can we do this? We're going to improve the ventilation in our ICU. We can't actually change the design of the ICU, but what can we do? And we worked extremely closely with our engineers, and we looked at the physical characteristics of the ventilation systems that we had, and we changed them. So the first thing we did was, prior to this, the air in the ICU was 50% recirculated air, whereas we changed that straight away. We could make that 100% fresh air intake, no recirculated air. We then sought to determine whether we could increase the rate of air exchange from 6 exchanges per hour to a higher number. At Sunshine, that was possible by sort of tweaking the existing machines. At Footscray, what we did, as you can see the photo on the right, is we basically put in some really, really big exhaust fans. And they were able to get the exchange rate at Footscray ICU up to around 8 to 10 exchanges per hour. And then further, what we were able to do with these high levels of airflow exchange was, if possible, create a negative pressure environment so that those people outside the ICU would be protected from the people inside the ICU that actually had COVID-19, and reducing the risk of transmission to many areas of the other areas of the hospital. And some of these strategies that we did, we actually, in one of the satellite ICUs that we developed at Footscray, we also were able to improve the ventilation with similar exhaust systems now. And they're still in place. They're still active at Footscray, and the ones in the satellite ICU are available to be switched on at short notice should we ever need to expand critical care capacity again. The next idea that was come up with, well, if we don't have single rooms, can we provide a physical barrier between patients and staff and everyone else? And my colleague Forbes McGain was inspired by the hood on a pram. And what he did with that sort of inspiration was think, could I have a plastic hood? And you can see an earlier prototype on the right there, Forbes and a couple of our staff acting as volunteers for the shot. It isn't actually a real patient, but evaluating an earlier prototype and showing a physical barrier between the patient and our staff members, such that that would reduce then the likelihood of droplets and aerosols being transmitted from the patient to the broader environment as well. They'd be contained within that plastic hood. But it was more than just a physical barrier. With working with the engineers at the University of Melbourne, we introduced a system whereby there was an exhaust fan which exchanged the air inside the hoods up to 1,000 times an hour. And then that air was filtered with a very high efficiency filter that removed particles, including the virus. So not only did it just physically protect the patient, the staff members and other patients in the unit from transmission of the virus, it also allowed us to consider treatments that were previously considered too risky to administer. And some of these treatments are here. So oxygen via a standard, when the guidance was being released by the Department of Health, oxygen delivered at 15 litres a minute, which is a relatively high flow, was considered to potentially spread the virus. Special nasal prongs running at high flows as well were also thought to spread the virus. And so their use was being said you can't use these outside negative pressure rooms or in isolation rooms, and they're a limited resource, not readily available. And if the numbers of patients was increasing, we really wanted to be able to provide these therapies, but safely. Nebulization, which is actually generating aerosols, putting drugs into a mist form and inhaling the drugs. And then special ventilation on the right there via a tight-fitting face mask as well. All these therapies were believed to significantly increase the risk to healthcare workers if they were used. But at the same time, they were all therapies that as clinicians we believed were likely to be effective for many patients with COVID-19. I won't go through this whole slide here, but if you can see my mouse, this is the number of particles, and that's a lot up there, and that's not many down there. And this is some of the treatments that we were providing that we thought we were unable to be providing, things like high flow nasal prongs and oxygen therapy. And there's not a lot of aerosol being generated. With on the left here, that's just when someone breathing, and that's just someone talking. So really the increase in aerosol numbers is quite small, and they're contained within the hood and they're filtered out. So we now had a lot more data. And with that data, that increased our certainty, our confidence, and it reduced the fear. And it meant that the staff were able to feel safe when using standard oxygen delivery methods, which hadn't been used or were in certain guidelines, both national and international guidelines, not recommended. The final thing that we thought we had to do was it was essential that we needed to measure what we were doing as well. And I was one of the lead investigators in a study that we've virtually got every patient with COVID that got admitted to intensive care in Australia. And we have collected outcome data on them to know how we were doing. And then we can look at any associations or changes in practice over time and see if that influenced outcome as well. And we provided weekly feedback to clinicians. And importantly, these data were also informing government as well, went to both all state and federal governments on a weekly basis about ICU utilisation, which was obviously, from a planning perspective, very important for healthcare administrators and politicians to be aware of. So if you just look at how did we do? As you've heard, just for your information, Western Health really was sort of COVID central in Australia. We had nearly 70 or so confirmed patients admitted to our intensive care units. To put that in context, it's just under a quarter of all Victorians that were admitted to intensive care with COVID came to a Western Health intensive care unit, and around 14-15% of all intensive care admissions with COVID nationally were in a Western Health intensive care unit as well. So we certainly bore the brunt of COVID infections from a critical care perspective, together with our colleagues at the Royal Melbourne and also our colleagues at Northern Health. And I want to also acknowledge we worked together quite well. One of the innovations that was put forward from an administrative perspective was a cluster model, which was actually driven by clinicians. And we partnered with Epworth Healthcare, and Epworth Healthcare actually helped us a lot in being able to share the load around when things got particularly tight in July and August. And they took a number of our patients and looked after them when we were getting close to capacity. And so that meant that no patient in Victoria who required intensive care was admitted to an ICU that was operating above normal capacity. So we're able to do the job that we do in a environment that was not severely stretched. And we had excellent survival rates. This is Jimmy Fennick. He was one of our patients from Sunshine, spent about 60 days in ICU. This was a photo of him in The Age. That's why I can show it here, because it's in the public domain. But overall, over 80% of the patients admitted to our intensive care units survived. And when you hear of some of the numbers that are, and the outcome data that's coming from overseas, it shows not only how ICU was able to respond, but as you can see from the banner his son's holding in the background, the ward staff, the rehab, but also the whole system, that it was able to operate at as close as possible to usual capacity. We didn't get to a level where we were doing things markedly different from normal. And I think that that's probably one of the reasons why our results are so good compared to our international peers. From a staff safety perspective, a very low number of ICU healthcare workers became COVID positive. Some of them were community transmissions, they got it in the community, but a very, very small number acquired COVID-19 in the workplace and all recovered, despite us looking after nearly 25% of the state's load. And certainly, anecdotally, the number of infections that we have encountered would appear to be at the lower end of what other health services have seen as well. Was there a difference between when we used the hood and then when we didn't? So the blue, as you can see there, is so-called phase 2. This was when the Victorian pandemic really took off in sort of July and August. The orange is phase 1, which was the initial sort of March numbers, which was mostly return travellers. And you can see that compared from phase 1 to phase 2, there was a lot more high flow nasal prong therapy, that's the HFNP, a lot more mask ventilation, and overall less invasive mechanical ventilation. So some of the things that the data that we produced along the way did appear to impact on patient outcome. As we all know now, the curve is well and truly flattened, and we have no new cases in Victoria for some time. We've had no cases in ICU now for around 7 weeks, and we're all enjoying lots of donuts. I will stop sharing.
Thanks, Craig. That was great. So, Marion, much of our advanced preparedness at Western was due to your insight into the virus's potential to spread and infect others. Were there things that surprised you along the way? I think you probably, were one of the first at looking at what was happening in China, but as you've worked this long now, since January, looking at the data overseas, was there things that surprised you or even still surprising you?
I think one of the biggest surprises was that these, what we call non-pharmaceutical interventions, non-drug or vaccine interventions, really, really worked. And that our community adhered to what we would have thought were fairly draconian measures in terms of restricting our freedom during the shutdown. And that our community really responded, and that made all the difference in the world. And so I am just so incredibly proud of the community in Victoria that really had saved our healthcare system. One of the other really pleasing things is the tremendous impact that masks have, and that they really do help to interrupt transmission. One of the real challenges, and this was different to SARS-CoV-1, the first SARS virus, is that this virus can transmit before people have symptoms. And that makes it extraordinarily challenging to control It's the reason we have to go and put people into quarantine to prevent the spread. And in addition to, so that before they get symptoms, and the masks here are also so critically important. And so to actually see, what we know in theory, what should work, but actually seeing it play out is it's just heartwarming. And I'm just incredibly grateful to our community with regards to that. And then I have to say, before I went to the United States, the last place I worked was Western Health, and I came back to the Western. And the togetherness, the community spirit, and the innovation, it's just a wonderful place to be back at.
Well, we're glad we've made you one of our Western Health family so quickly, Marion. So that's great. As we pointed out, COVID Central, I think, was what Craig described Western Health as. And to many people, those of us inside and outside, we felt like COVID had taken over our entire healthcare system. But it didn't stop other hospital services from being required. And so, Russell, can you give us a couple of examples of what other innovative things we did to try and manage the demand on our system while we were still managing COVID?
Yes, so as you say, the hospital had to keep going. And as Marion has had to jump off, so she sends her apologies to have to leave. But healthcare did drop because, as Craig said, people were afraid to come to hospitals at the fear of getting COVID. So we did see presentations come down. But we also had a lot of patients to support. We did that differently in the community. So as we're doing today, Zoom and Teams and many other platforms suddenly got a very different airing in use, and we adapted very quickly to telehealth. So we had a lot of clinics now move to telehealth to do consultations. So one of the stories that I love that I heard from Wave 2 was the fact that we had an outpatient consultation with a truck driver who was on his way to Shepparton. He pulled over his truck, had his consultation, and then kept on going. Ordinarily, we'd have had to pull that poor person from a day's work into the hospital, have them sit in the waiting room. All of those things are now very challenged with COVID, but telehealth has been very seamless. And I think certainly from the patient's feedback and family feedback, it's actually been really positive. The other thing to flag, though, is that we opened Joan Kainer about a year ago, just over that now. And we had our busiest month of all time in August, which was pretty much in the height of Wave 2. And we had 579 babies join us. So we had to come up with very innovative ways to keep both staff and patients safe in the birthing procedure. And that caused some challenges, but we were able to do that and meet it. And I think, as Marion said, and as Craig demonstrated in the presentation, the agility and the innovation of people at Western Health, and that sort of real can-do attitude as an absolute kind of asset that has served us very well through COVID and has meant that we can continue to deliver services and do things very differently and very agile. And staff have been incredible. They've took on new jobs. They've stepped into roles that they wouldn't otherwise have thought of doing. We supported aged care in the community now. 8 months ago, if you'd have told us that we're going to run aged care that private companies ran or support them in the numbers that we have, we'd have sort of just laughed and fell about. But we've supported about 110,000 1,100 COVID positive Victorians in aged care across the West. We've done lots of end of life planning with families and patients in those situations, and staff have had to endure incredible grief, including in the inpatient setting where visitors couldn't come. So I think it's been an interesting period for us, but we've learned a lot. And I think that the treatment of patients outside of COVID has still happened. And I think that's a credit to the hospital that we could keep doing that and keep people safe.
Great, thanks, Russell. So Jason, we heard all the innovations in the ICU area and the change of practice, but your job's bigger than ICU. You look after other critical care services. So out of the changes that we had to implement to adapt to the different way of working, what do you think some of the things that we might keep that, we won't change?
One of the opportunities we have with reduction of elective surgery. So after a while, we through the department's guidelines. We reduced surgery to just emergencies and category one surgery predominantly. But what it gave us is the opportunity with the staffing that were available because of the reduction in that service, is the creation of what we've called the critical care outreach team. So that was the team that we formed, which is usually formed from the ICU liaison team. So they're responding to code blues and medical emergencies out on the wards. But we also formed the anaesthesia team, so a senior anaesthesia team membership. So they're highly expert in airway management and hemodynamic management on the wards or in theatre. So we formed them as part of the critical care outreach team, in addition to the coronary care nurses as well. They're all going out there. So really to expand that service, because what we knew is we were trying to keep these patients well on the wards and prevent them to coming to the intensive care unit. But we knew that the ward staff needed additional support. And they were challenged with, I guess, the time and effort it was taking to put the PPE on between patients. But these patients were really unwell on the wards, and our team, not just the ICU team, the anaesthesia team and other members of the liaison teams were going out there providing that additional support. So that's something we would definitely like to keep moving forward, and also working with our education department. So going up there, providing that rapid response service for the patient, but also following up with ongoing education. So the ward staff are really being developed on the go in a really proactive manner to prevent patients, to be really, I guess, increasing their capability to care for acutely unwell patients on the ward. And that led to a lot of preventable readmissions to our intensive care unit.
Yeah, great. Thanks, Jason. Russell, if I ask you, what have you learnt over the last 7 months, or what has surprised you? What would you say?
I don't think it surprised me, but it's kind of reconfirmed my belief that health service staff are incredible and they love a crisis, and they often come to the fore when a crisis presents. And I think that's the world over. Our staff were dealing with some of the same pressures that colleagues on the call were dealing with. They had homeschool, they had family members at home, and they were coming into what was potentially a very dangerous environment, fully bedecked in PPE and having to care for some very sick patients with COVID. But they kept coming, and they kept putting their hands up to go into new areas. Our Resi InReach service is usually 7 staff members. It went up to 79 in a week. And all those people were volunteers to go out and do that work. As Jason said, our anaesthetists from theatres said, well, we're not working in theatres, so we'll go and support the wards as critical care outreach. We had staff that were putting their hands up from education teams that said, well, I used to work in ICU, please retrain me. Some of our, therapists and social workers became PPE distribution champions and experts in all things logistics and stuff they probably never thought about. And I think, that didn't surprise me, but it reassured me that the health service staff are in care for the right reasons. It's to support their colleagues, their patients, and the community. And I think that was a really humbling thing to see at Western Health, particularly because that's kind of what we see day to day, but also across the system. But I think to echo Marion's point, the community response was also incredible. The gifts and donations that we got from community, the food parcels that kept coming in, the foundation team became our logistics hub for coordinating donations. It got so big, but the tolerance of our community, I think, was incredible across the state. As Marion said, we had some pretty big restrictions on freedom that we're not particularly used to. And that lasted for a very long time. We didn't allow visitors in the hospital very often, apart from in extremis. And people tolerated that and understood that and supported the healthcare staff to come to work, to do their job, but also to kind of follow the rules in a way that wasn't surprising, but was really kind of heartening to see that people took this really seriously. And I guess the media coverage from New York about how things can get out of control really quickly probably, helped the psyche stimulate a bit, because nobody wanted that in Victoria. So it's been hard work, but it's been, hugely rewarding to watch the great endeavours of staff and community to actually respond to what is a 1 in 100-year event, let's hope.
That's right, let's hope. And Craig, what about you? What surprised you most over these last 7 months?
I just want to concur with the I think what surprise is probably not the right word, but most pleased is how our community came together, and as we've heard, really on the whole accepted a set of some very draconian restrictions. I mean, I reflected, although I was working and coming to work, I was working and coming to work. I wasn't at home. I wasn't, stuck within a very small sphere and only going out 1 hour a day from my house for various bits and pieces. So I was very cognizant of the demands that were being placed upon those that did not have the same opportunities of what I had to interact with other people. Although obviously some of the work that I was required to do and the sadness that I saw and experienced with families losing loved ones to COVID-19 was obviously very, very distressing too. But when I reflect, I was just on a teleconference with some US colleagues and European colleagues earlier in the week, and from the stories that they're telling of what's going on there, it's just so proud to be a Victorian and Australian that I know there's been a bit of political shenanigans, but within the whole, there's been sort of good bipartisanship, and the machine, as I said, the machinery of government has actually got on and done what was needed to happen. Whereas the contrast with other countries where that hasn't been allowed to happen because the leadership has, for whatever reason, taken a different path, it's led to very poor outcomes indeed. From the good thing from an ICU perspective is, as we heard, we had a number of staff come back and retrain. A number of them are choosing to stay on, which is really good news, because ICU staff are always in short supply. So the fact that a number of them who left and came back and decided, I actually really miss this and staying on, that's been great. But also the collaboration that we've been able to develop, firstly with the university, we're always with the University of Melbourne, with the Department of Engineering there, and the atmospheric scientists with the design. There's going to be ongoing research in that area. I was also involved in some writing a paper for the state government in conjunction with people from the Faculty of Arts at Monash University regarding the ethics of health care and potential reduced access to healthcare when demand is greatly exceeding what is available. So those sorts of relationships that we've been able to develop, I think will, in the end, only enhance our ability to deliver the best possible care and treatments to our community.
Great, thanks, Craig. So I'm going to say to our corporate friends that they can actually start to use the Q&A tab on the bottom of the webinar if they'd like to do that. And while we wait for a couple of questions to come in, one that I would probably ask the panel, and there's a couple of you that could answer it, is so we heard about the open plan of the current Footscray ICU. What about the new Footscray ICU? What's it going to look like, Craig?
Okay, so the new Footscray ICU consists of 2 pods of 11 beds each. And the functional brief requested that each of those 22 beds is a single room. And so they're going to be single rooms. And that also that there are a significant number of negative pressure isolation rooms. I must admit, I remember last year, actually, when we were in the earlier phases of planning for the new Footscray ICU, saying it would be really good if one of the pods could actually be isolated and have it become a negative pressure isolation whole pod in the event of a pandemic. Anyhow, 3 months later, there was a pandemic. So one of the ICUs there will be basically able to be converted to a pandemic ICU.
So the old adage about careful what you wish for, Craig, is
Very much so.
quite true.
Very much so. Yeah.
Yeah.
Like Marion, I've been around a little while now, and we, experienced swine flu and the other things that we've had over the years. So pandemic planning is something that there's been a bit of attention paid to, and it's really obviously come to the fore now.
Yeah, thank you.
I guess
Thanks,
that's the other thing. That's the other thing to say. You've opened the door, so I'm gonna carefully tread into it a little bit. But one of the things that is another testament to the staff at Western is they actually managed at Footscray, while dealing with huge numbers of COVID patients, they managed to continue to give up time to evaluate the bids for the Footscray Hospital and actually, score and come up with a set of recommendations for government on, which way forward. And obviously government have announced a preferred bidder. We're still in a commercial process, so we've got to be careful what we say. But I think, as Craig said, we've been looking very carefully at the really harsh lessons that we've been learning through COVID and looking to apply them to the new facility. And I'm never going to say it's going to be pandemic proof, but it will have all the learnings we can possibly get our hands on into that, so that we're as best prepared as we can be to go forward. Somewhat different to the current facility that we've nursed and cared for patients in, I should say.
So Russell, there's been a couple of questions that have been sent through ahead of time, and a couple of them are about New Footscray Hospital. So mindful of what you've just mentioned about the commercially sensitive period. But one question that's asked is, when will the announcement of the New Footscray Hospital tender be officially made?
In essence, so the government have announced the preferred bidder, and that triggers a process where there's you still got to reach what they call commercial and financial close. So we're in that process of working with that preferred bidder to get to that point. My sense is that we should get to financial close early in the new year. I'm fingers crossed for sort of January end thereof, but it could be January, early February time. So I think once we get to that milestone, then there'll be big fanfares and lots of announcements, and staff and community will get to see at that point the renders of what the building will look like and how the campus will take shape. So it's a hugely exciting time. I'm sort of jumping up and down on my toes because I've seen them. I know kind of what's coming, but I can't share it too widely because I'm not allowed. But I think it's going to be a fantastic facility for the West. And as Craig's kind of outlined, there's a lot of great design in there that will support excellent world-class patient care for our community, which is what we're all about.
Right. And one other question, I don't know whether you actually know the answer to this, but we'll put it out there, is what do we think will happen to the old Footscray Hospital and site?
That's an easy question, Sue. There's no answer to that one.
Right.
So the site belongs to government, and the Premier, when he announced the new hospital, publicly committed to a process of consultation on what would happen to this site. If I was a betting man, I'd say something to do with socially affordable housing and some mixed-use development, because it's a big site. But the jury will be out and the public will get a view on what is important for this community going forward.
Thank you. So questions just come in, Craig, for you, and I'll read it to you.
I saw it.
Oh, okay, there you go. Do you want to answer it then?
Yep, sure.
So go ahead.
So the federal government actually sponsored national COVID guidelines, which I'm also part of. And so we had the ability to rapidly synthesize available data, both observational and randomized control data from observational studies, such as the Sprint SARI data that I showed some of you earlier, but also the so-called randomized controlled trials. That's the gold standard of clinical trial. And then there are what's called a living guideline, and that's available for all clinicians and updated weekly, and there's regular announcements put out when the information does change. I think that it's very important that we have a process like that. During the pandemic, there's been a number of, how should we say, I think at multiple levels there's been learnings. There's some aspects of science became politicized. There were journal articles published without adequate peer review and subsequent retractions. And the other phenomenon that we're seeing as well is the so-called, is the release of results to media prior to peer review, and also the pre-publication websites where researchers can put their preprints up on a website prior to review, and that's often not the final version of what comes out. So sort of synthesizing that mire, working through that mire of information and actually determining when you should change practice. And this is a key point. We don't need big, fancy randomized controlled trials for everything. We didn't need it for penicillin to treat infections. The effect is so large. But many of the things we do now, the treatment effect is relatively small. And therefore, you have to be confident that the benefits outweigh the risks. And so one of the things that I hope that we will transition back to is a period whereby scientific discovery is scrutinised properly before it's promoted widely in the media. And we've all seen remdesivir went from being approved by the Australian government and large amounts of it being bought to now the WHO recommending that remdesivir shouldn't be used because it has no effect. And it wouldn't surprise me if other interventions that have been shown to be effective in a pandemic are not effective in systems that aren't operating outside their usual capacity.
Thanks, Craig. So with that, I'll invite Julia back on to thank our corporate sponsors for joining us. And just one final comment about, isn't it so good to hear how science is science and is really informing decisions we've made and what we've done. And if the pandemic's done anything, I think it's put science ahead of financial concerns and probably put the balance back where it needs to be. So thanks. Over to you, Julia.
Thanks, Sue, and thanks to everyone. You're right. It's as much as it's not been the easiest time, there's some very exciting times ahead in terms of the research and the data findings that'll come out of the last 12 months. Thank you to everybody who's joined us. We are going to share with you the results of the poll that you did earlier, and I don't think that it will be a great surprise to anyone to know that downturn in business was probably one of the main things that affected your organisation. But I think the other thing that came through strongly for all of us was the mental health in the workforce as well, which we know we've all been impacted by on some level or other. Thank you again for joining us. Thank you very much to our panel and to Jason and to Marion, who both had to shoot off early to other commitments. But for everyone who I know is incredibly busy, making the time to come and talk to us is hugely appreciated. Thanks very much, and we'll see you all soon. Thank you.
Thank you.